Okay, so this video is going to go over the answers to the activity with bipolar disorder. So we looked at a patient with very specific behaviors. So if you look at the first risk for injury, the first nursing diagnosis, we have hyperactivity, agitation, purposeless movement, poor judgment. So that's what we really wanted our interventions to look at. So the three that I had, and these are not the only ones that you could have had, but the three that I had specifically for this are a low stimuli environment to help with less distraction, firmly redirect energies into a more appropriate channel, such as walking. So this is especially something that can be done with the nurse, and it allows for goal-directed activity with the nurse present. We want to maintain a calm, controlled, collected demeanor. So things like agitation, anxiety, those things are contagious. And so if the nurse can display what is appropriate behavior, then that is going to help role model what we expect in the patient. So the next nursing diagnosis is risk for violence, self or other directed. And this patient is manic, they're delusional. They have hallucinations, impulsivity, and very labile mood. So first thing we need to do is make sure that we are checking on this patient. So every 15-minute checks are going to be very important, and that would be part of their suicide precautions as well. And that's making sure that the patient and the environment are safe and that they're able to have a no suicide contract. Make sure that there are enough staff visible and present. And often just the show of force can help to mitigate any um, likelihood of a violent episode. Then we want to set limits with firm, concrete, enforceable consequences. So the patient must know the consequences of their actions, and the nurse has to be able to follow through with what he or she says. Imbalanced nutrition, less than body requirements. This patient is very much has lost weight, has amenorrhea, can't sit still long enough to eat. So those are the things that we really need to keep in mind. So one of the first things that we do with a patient like this is we give them their preferred finger foods. So if this is a cheeseburger and french fries or chicken fingers or something along those lines, it may be not the most nutritious, but at this point we need to get calories into this person. A boost type of shake mixed with ice cream would be great. Something that they can pick up and carry with them. It doesn't require them to sit still in order to eat the meal, and it has lots of calories in it. So the rationale for that is they can't sit still, but they still need those calories because of how active that they are. The next one we need to do is monitor I's and O's, as well as intake and output of their fluid and foods, as well as their daily weight. And that's really just to help the nurse monitor and see if any further interventions are needed. The last one is try to have that nice calm atmosphere when it is time for the patient to eat, and that is really going to help so that the patient doesn't get so distracted. So remember, this person is very distractible, and this will hopefully help so they can actually focus on eating, which is what we want them to do. The next one has to do with its disturbed thought process. So this has to do with delusions of grandeur and persecution, inaccurate interpretation of the environment, as well as racing thoughts. So you want to make sure that you are not agreeing with a delusion, but you acknowledge their underlying feelings. So that's really hard sometimes. The patients can be very delusional, and you don't want to agree with them because that just reinforces the delusion. We also don't want to argue with them because that makes things so much worse. People dig their heels in and then they really believe that delusion. And so instead, we look for those themes in communication. And the rationale for that is what the person is feeling is actually more important than what they're saying. It's also helpful to redirect attention to reality-based activities. So we do want to, try to keep them involved in what is actually going on in their environment. So whether that's a craft, whether that's lunch, whether that's time to shower, whatever those things may be. And the rationale for that is that it can help take the patient's mind off of the delusions and help them focus on what is real. The third one is simple, concrete statements. And just remember that the rationale for this is the patient has poor concentration and we want to be able to communicate with them. The other part that I do want to point out here is that it is helpful sometimes to point out reality, or that we need to point out reality. So we may have to say things like, although you believe, someone is after you, I don't think anybody is after you. And it isn't arguing with them, it's validating their thoughts because you're saying you believe that, but it's also pointing out the reality and saying, I don't. And we can do that with delusions. We can also do that with hallucinations, because we can say, although you hear those voices, I don't hear those voices. And that can be helpful so that patients can learn to recognize the difference between reality and hallucination or delusion. The next one is impaired social interaction. So this patient is really having a lot of issues socially. They are manipulative, have unsuccessful social interactive behavior, provocative behavior, which is very problematic, intrusive, taunting, loud, and profane at times. So one of the things that we need to make sure that we do is when the patient does have positive behaviors, we reinforce that. And when we say reinforce, we don't mean, oh, you're doing a good job. What we actually mean is that you're acknowledging it. So I noticed that you were able to have a 5-minute conversation with so-and-so, and there weren't any issues with it this time. So when we acknowledge it, that helps to reinforce the behavior, and it helps for repetitive desired behaviors. The next one is reinforce clear boundaries between the client and nurse. This is a patient who will often blur those boundaries, and so we have to make sure that those boundaries are stated very clearly. And the rationale for that is because when somebody is manipulative, they'll try to be your best friend, or sometimes more than that. And we have to ensure that we are the ones that are setting those boundaries. One intervention that's often hard, and it was hard for me at first too, is you might have to interrupt this person. So if you don't interrupt them, they will talk forever and you won't get a word in edgewise. So we have to really become okay with the fact that it's all right to interrupt them, even though that we've been taught not to do that. It goes a little bit against the grain. And the rationale for that is they will continue to talk without a few breaks and you will never get to talk. So I do have a fourth one in here, and really the key is that this person is likely to need solitary activities at first, or nurse-led or staff-led activities. So please keep that in mind. The patient, if they're having all of these social issues, this patient is not ready for group interactions. They're not ready for, playing games with the other patients. They are ready for you to have one-on-ones with them, hopefully. And the next thing that we might do is something non-competitive, where they're solitary, so like stretching. So it's a led activity by a staff member, and they don't actually have to interact with anybody in order to do it. So that might be an acceptable way for them to participate in a group. The last one is risk-prone health behaviors. They're having difficulty sleeping. That's a big problem here. Not drinking enough fluids and things. And so we address the food and fluids. So here's where we really need to address the sleep. So we want them to establish a sleep routine, and you guys have talked about how to do that. Then the body is more relaxed and ready to go to sleep when it is time. The next one is provide a relaxed environment. So dark, sometimes you can do quiet music, but sometimes that's too distracting. So it really depends on the patient. That is something I would think about, is if some sort of relaxation music would be helpful, and I'd probably give it a try. And deep breathing exercises before bed. So having them, going in and doing some of those deep breathing exercises before it's time to sleep. And that allows the environment to be more conducive for sleep for the patient. And then the other one that, especially early on when this patient is manic, they're going to need sedative medication. There isn't any other way that we are going to get this person to rest, unfortunately. Usually sedative medication is our last go-to. Here it's going to be one of our firsts, because this person could die if we don't get them to rest, to sleep. So we are going to ensure that they sleep with some medication. And that's the rationale, is that this person's manic and they're not going to rest otherwise, and it's to the point where it's potentially lethal. So I'm just going to end this video here with just those particular answers, and we'll start up with the medications.